Good morning, good afternoon, good evening, wherever you are, and welcome to this webinar on the expansion of access to hepatitis B birth dose. This session is presented by WHO and Gavi with the support of TechNet. You can listen to this session in English and French. To do so, please click the globe icon that is at the bottom of your Zoom window and select the language in which you'd like to listen to this session. Now, let me explain that in French for our francophone audience. Bonjour et bienvenue. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en forme de globe et sélectionnez la langue dans laquelle vous souhaitez écouter cette session. We'd be happy to know who's with us today, so feel free to introduce yourselves in the chat box and tell us your name and where you're from. You can also use the chat box if you need technical support. I'll do my best to help you. If you have any questions during the presentation, please use the Q&A box. It's available at the bottom of your Zoom window. You can ask your questions at any time, and our panelists will answer them in writing when they can, and also some questions will be selected to be answered during the Q&A session. Finally, this session is recorded. We'll share with you next week the links to the video as well as the slides by email. And I hope you'll enjoy this session, and I'll give the floor to Stéphanie. Stéphanie, c'est à toi.
Merci, Alex. Thank you so much. Hello, everybody, and welcome to our webinar today on protection from birth, expanding access to the hepatitis B birth dose. I'm so happy that you've been able to join us from wherever you are calling in from today. And thank you also for making time in your busy calendars for such an important webinar. It is a long one. We hope to have your attention for 2 hours today because there's so much rich information to cover under this topic. So we will try to keep it interesting, keep it moving. We'll take a little break in the middle just to give you a chance to stretch your legs. But we do hope that you can stay with us for the full duration of today's webinar. It will be available afterwards by recording, as Alex mentioned, so in case you do have to step away, but really looking forward to having you with us. I'm joined today by several other technical experts from WHO and Gavi, both from global and regional levels. So you will benefit from hearing from several different voices who are experts on the topic. And I will ask each of our presenters to quickly introduce themselves before they begin speaking, so you can understand exactly who it is that you're joined by today. So here's a brief outline of what we're going to cover. So we're going to go through some background on the global hepatitis goals and frameworks, as well as the regional context for both the African and the Eastern Mediterranean region. These are the 2 regions that we're going to be focusing on today, because as you will learn, there is still a very high burden of hepatitis B in those regions. And to date, we don't have quite the level of optimal coverage of the hepatitis B birth dose that we would hope to see. And so this is why we are focusing our efforts on these regions today, although this does obviously remain a priority in all regions and countries in the world. And then we're also going to discuss some of the updated guidelines and toolkits available for facilitating the NITAG decision-making process, as it is well recognized and established that national immunization technical advisory groups are such key players in facilitating country decision-making around vaccine introductions, and also the prioritization and optimization of vaccine schedules, especially in face of such competing priorities and limited resources that we see becoming an increasing problem and challenge. And then we'll also talk about the updated Gavi funding guidelines and support available for introduction of the hepatitis B birth dose in Gavi eligible countries. So just before we get started, though, we do have a little quiz for you just to test our knowledge on hepatitis B and the birth dose vaccine, just to get an idea of what we're all coming in with today. And so I'm going to hand the mic to Simba to read out these questions while I launch the poll for you.
Thanks very much, Steph, and hello, everyone. So my name is Simba Mabaya. I work with Gavi. I'm a senior technical advisor at Gavi. I work on the hepatitis B birth dose vaccine as well as the rabies post-exposure prophylaxis vaccine. So we have 5 questions on the screen. I think every one of us should be able to see. If you can't see them, please let us know. And for each of the questions, there's one correct answer. So I'm going to read through the questions just to help with the translation for those of our colleagues who are Francophone. So the first question is, why is the Hep B birth dose an important public health intervention? For that, we have 3 options. First, it significantly reduces the risk of chronic hepatitis B infection in newborns. Secondly, it eliminates the need for subsequent Hep B vaccinations. Or third choice, it is only effective in preventing hepatitis B in adults. I'll give you 3 seconds to respond to that. Then the second question, what is the ideal timing for giving the hepatitis B birth dose? So this is the timing since birth, after birth. So what is the ideal time for giving the hepatitis B birth dose? Within 4 weeks, within 24 hours, within 1 week, within 14 days. So those are the four options. Third question, which 3 diseases are targeted in the triple elimination framework? First choice, hepatitis B, HIV, and syphilis. Second choice, hepatitis B, tuberculosis, and malaria. Third choice, HIV, syphilis, and tuberculosis. One correct answer. Fourth question, have you used the NITAG recommendation process toolkit in your work? So I think there's no one correct answer in this case. So it could be yes, could be no, or that you're planning to use it. Then last question. In this one also, there's no one correct answer, but you have to just make one choice. What do you consider the biggest challenge in implementing hepatitis B prevention strategies? Is it funding? Is it training and education? Is it access to vaccines? Is it access to skilled birth attendants? Is it public awareness? Thank you, and back to you, Steph. I see the questions also have been posted in the chat in French.
Great, thank you. So we're not going to share the results because we're going to revisit this a little bit later and see if anything that we cover in the first half of the webinar changes what we put in for our responses. But now to start us off on the technical aspect of this webinar, I'm going to hand the microphone over to Dr. Fumi Lessi, who will start us off with a background and context on global and regional hepatitis frameworks. Over to you, Fumi.
Hello, everybody. Thank you very much, Stephanie. My name is Dr. Fumi Lessi, and I lead the viral hepatitis program here at WHO headquarters. And today our focus is on hepatitis B birth dose and the introduction of new vaccines. But before I delve into this, I would like to set the scene to establish the context so that we can understand why this intervention matters and how it connects with the broader elimination agenda. And again, how it translates into lives saved and diseases averted. And this is a slide we're very familiar with the huge prevalence of hepatitis B, with more than 254 million people who are chronic carriers. The slide on the right shows the prevalence of hepatitis B in different regions of the world. And you would see that in AFRO and in WIPRO are the areas with the highest prevalences exceeding 5%. And just to mention that in some parts of Africa, West and Central Africa, the prevalence of hepatitis B exceeds 8% in the general population. There's also a large burden of deaths from viral hepatitis, and I will get to this. And to mention that hepatitis B is highly infectious, routes of transmission include blood transfusion, which we know very well, unsafe injections, which is very common in developing countries, and mother-to-child transmission, even child-to-child. Recently, we've been talking about sexual transmission, and indeed, because it's a very infectious virus, it can be transmitted sexually, but of course, the characteristics of sexual transmission are completely different from mother-to-child transmission. Next slide, please. The next slide shows us the unacceptable mortality from viral hepatitis. The images in orange flag the hotspots of mortality. And we know already, and there's strong scientific evidence that shows that these viruses are highly carcinogenic. It causes over 3,000 deaths per day. And that's a lot for vaccine preventable disease. And the images below show what a normal liver looks like, a scarred cirrhotic liver, and then the development of cancer. In Africa, liver cancer occurs in young adults between the ages of 35 and 45. So it's really an important thing to prevent these infections. Next slide, please. So the next slide shows the global commitment that has been made since 2016. And this is in the Global Health Sector Strategy that shows that it is possible to eliminate viral hepatitis and reduce the incidence of infection by 95% and the mortality from liver disease, liver cancer by 65%. And these targets are shown on the left. Now on the right, I want to highlight some priority high impact interventions for the entire response. And the first two are the birth dose and preventing mother-to-child transmission. And of course, safe injections, harm reduction, testing, and treatment are key, but will not be the subject of discussion for today. So next slide, please. And the global targets have been well established. And you would see we have targets for 2020 targets, the 2025 targets, and the 2030 targets for the impacts and for the two main programs that are involved in this response. Next slide, please. This slide shows, just to highlight some of the progress made towards hepatitis elimination. The 2024 Global Hepatitis Report highlights a few important things. It flags the success of childhood hepatitis B vaccination. It also alludes to poor access to hepatitis B birth dose, mainly in Africa and EMRO. And it gives us the data from 187 countries that the highest incidence of new infections occur in the Africa region. The mortality from liver cancer is rising, very unlike other infectious diseases. And in terms of testing and treatment, very initial progress has been made with diagnosed and less than 3% treated. Next slide. And I would like to make three main points. Now, this slide shows that over 65% of new chronic hepatitis B infection in the Africa region, that's more than 771,000 people. And it's interesting that if you look at the Western Pacific region, with a greater burden, they have a lower number of new infections, and that can be attributed to the fact that they have birth dose and good childhood coverage. Next slide, please. Now, this slide shows the SDG targets of less than 1% of surface antigen prevalence in children less than 5. This was accomplished in 2020. It's an important SDG target, but you will see that in the Africa region, this target was not achieved. And some of the characteristics of the infection in AFRO region is the inadequate coverage of the childhood vaccine, we can see that the birth dose in this region is only 17%. And in terms of birth attendance by skilled health workers, it's less than 70%. I flagged this because it has implications for administration of birth dose, and I know we'll come to those limitations very shortly. You'll also see that in the EMRO region, the target was reached, it was 0.8%, but we can also see that their birth dose coverage is the second lowest after the Africa region. Next slide, please. So, in terms of access, this slide shows the poor access to hepatitis B birth dose that occurs in the regions with the highest burden of disease in children. The green color on the left shows the countries that have hepatitis B birth dose, while the gray in most of Africa shows the countries that do not have hepatitis B birth dose. If you look also on the right, the blue bars show countries where there is a cost attached to birth dose. So people have to pay out of pocket for hepatitis B birth dose and sometimes the childhood vaccination. The biggest bars for the blue, where it is out of pocket, is also in Africa and in the EMRO region. Next slide, please. So the WHO recommendation in 2024 was developed to strengthen the prevention of mother-to-child transmission using antiviral prophylaxis. The recommendations are in countries where we have hepatitis B positive women with high viral load. Treatment using tenofovir can be given to these women to reduce the viral load and reduce the transmission and support the hepatitis vaccination in preventing mother-to-child transmission. Ultimately, we're talking about reducing incidence, reducing death rates. In 2024, the recommendations were expanded to universal prophylaxis, very much like the HIV option B+, where women are given prophylaxis. The graph shows the country of Malawi that has really embraced this guidelines and this recommendation and has started testing and treating hepatitis B mothers. Currently, there is an ongoing evaluation to see how effective this has been in Malawi, and that is very exciting news for us. Next slide, please. As a round up, I just want to focus a bit now on triple elimination. Now, what is triple elimination? It is really addressing mother-to-child transmission of 3 infections, the HIV, hepatitis B, and syphilis. And at this point, not just the baby, but looking at the mother-to-baby pair. And these 3 infections have some overlapping characteristics that they can be sexually transmitted, they can be detected in mothers, they can be prevented. And it recognizes integration of disease as so important, using pre-existing PMTCT platforms and incorporating hepatitis into these platforms. Now, PMTCT, therefore, is preventing this transmission, and it again is built on a foundation of hepatitis B vaccination. Next slide. And this is very important, and several partners, including global funds, are supporting the PMTCT process. So on final reflections, just to take away that chronic hepatitis B is a global public health priority and the most important cause of liver cancer, which can be vaccine preventable. The scale-up of hepatitis B birth dose and strengthening the childhood vaccination, they must be priority interventions, especially in countries and regions with a high prevalence, as we're discussing today. Note that the new guidelines provide an additional strategy. They do not replace hepatitis B vaccination, and that is an important context. And government ownership partnerships, including with the community, must be part of the way forward. Government ownership will provide the resources to strengthen the health infrastructure, the hepatitis services, and bring partners like Gavi to support the introduction of hepatitis B vaccines in that context. And on this note, I wish to say thank you very much for the opportunity to be part of this meeting, and I'm available for questions as required. Thank you, and over to you, Stephanie. And of course, we have some toolkits available, and we can scan this. It gives scorecards of the 6 WHO regions and the status of hepatitis in all of the 6 regions. So thank you, Anova.
Thank you so much, Funmi. And now I'm going to hand the mic over to Dr. Sidi. And just a reminder that questions will happen at the end, but if you already have questions for Dr. Funmi, please do feel free to put them in the question box, and we'll also be able to take them live at the end. Over to you, Sidi.
Thank you, Stephanie. So good afternoon, everybody. My name is Sidi Njai. I am immunization officer and in charge of supporting the NITACs in the African region. But I'm also standing for hepatitis B birth dose focal point. So just a landscape on hepatitis B infection in the region, and also the introduction of hepatitis B birth dose in the African region. So as you've seen the slide shown by Funmi, so there is a high burden of hepatitis B infection in the region, but with low diagnosis capacity in the region and treatment also. So you see that about 65 million people are living with hepatitis B infection virus in the region, and causing like 272,000 deaths in the region. And you see that the capacity of diagnosis is really very, very low in the region. Slide. So as aligned with the global framework, so the WHO AFRO developed also a framework for integrated multisectoral response to tuberculosis, HIV, sexual transmitted disease infection, and hepatitis B from 2021 to 2030. One of the milestone is that 35 member states have to introduce hepatitis B vaccine by 2030. So we are very far from this target. We'll see in the next slides. So there is also milestone, cross-cutting milestone regarding the integration of HIV, TB, viral hepatitis, and SIT to the other communicable diseases and non-communicable diseases treatment. So we have also, okay, so yeah, please. So this is the slide showing the introduction of hepatitis B birth dose in the region. So as end of 2024, we have 17 African countries that introduce hepatitis B birth dose. But I think that this number of countries will be increasing annually with the renewal of Gavi support that is expected to significantly accelerate and expand hepatitis B birth dose implementation across the African region. Slide. So this slide shows the vaccination coverage for hepatitis B birth dose. So you see that the coverage has been steadily increasing in all regions, but remain below the 90% target. So the African region has the lowest coverage of hepatitis B birth dose and are stagnating at 17% since 2 to 3 years, because the number of countries also did not increase since then. But we are expecting to have more country introducing this vaccine in the next year. Slide. We have here the hepatitis B birth dose coverage in the African region as 2024 WANIC data. You will see that in the red bar you have the hepatitis B birth dose, And in the blue one, it's the coverage of hepatitis B, the hepatitis B, the third dose, with given with the DTP pentavalent or hexavalent vaccine. So you will see that the coverage of hepatitis B birth dose is still very slow in many of the countries, but we have 3 countries that have very high coverage. So that shows that we can, if we implement the right strategies, integrating the immunization, the hepatitis B vaccination, and the maternity wards, training the healthcare workers, we can have high coverage as the other vaccine given at the birth dose. But some countries also need to improve this coverage. Really, if in the country you have the birth at the health facility very low, so you need to implement strategies to really target, reach the children at home, and but also the community level, and also the communities where you have very low access to the health facilities. And we have also some countries that are not reporting the dose within the 24 hours, so such as Angola, Mauritania, and Uganda. Slides. Thank you.
Thank you much, CD. And now I will hand it over to Dr. Mohammed Jamil to cover the background for the Eastern Mediterranean. Over to you.
Thank you, Stephanie. Good morning, good afternoon, everyone. I'm Mohammed Jamil, Technical Officer and focal point for HIV hepatitis STIs in WHO EMRO region. So I will add a little bit of context and progress in terms of hepatitis B birth dose coverage on top of an excellent overview that my colleagues have already provided. So in the Eastern Mediterranean region, where we have 22 member states across Middle East and North Africa, the Gulf countries, and countries in South Asia, we have a significant burden of both hepatitis B and hepatitis C. In fact, the EMR region has the highest burden of hepatitis C in terms of absolute number and prevalence across all WHO regions. We have a significant hepatitis B burden with 15 million people estimated to be living with chronic hepatitis B. We have an incidence of 86,000 new infections every year, and together hepatitis B and C are accountable for nearly 100,000 deaths every year. But when it comes to coverage of testing and treatment for hepatitis B, only 15% of the estimated people living with hepatitis B have been diagnosed, and 2% are receiving treatment. And this is comparable to the global average that you heard from me. For hepatitis C, we are doing a little bit better than the global average, with 49% diagnosed and 35% who have received treatment. And this is attributed to the significant scale up of hepatitis C testing and treatment in Egypt. Next slide. Now, in terms of hepatitis B birth dose introduction in the EMR region, so 17 out of 22 member states have introduced hepatitis B birth dose. However, as you heard from previous speakers as well, the coverage, the regional coverage remains significantly below the 90% coverage target. So consistently remaining below 50% for hepatitis B birth dose. It is a little bit better for 3 doses, so almost 79% in terms of the regional coverage. So of the 5 countries that have not yet introduced or fully introduced hepatitis B birth dose, Pakistan is one of the countries where there is a partial introduction in some regions and provinces through domestic funding. There's not yet any Gavi support for hepatitis B birth dose in Pakistan. 2 countries, Sudan and Somalia, have plans to introduce in this year or next year through Gavi support, and 2 countries still don't have any plans yet for introduction of birth dose. Next slide. So our response in the regional is guided by the framework of our regional action plan for HIV, hepatitis, and STIs, which is aligned with the global health sector strategies that you heard in earlier presentations as well. And it supports, fully integrated service delivery for all these diseases. And of course, hepatitis B birth dose is a key intervention for prevention of hepatitis B incidence and mortality as well. In 2024, we conducted a regional assessment of progress towards achievement of triple elimination of mother-to-child transmission with UNICEF. And I will give you a snapshot from this assessment in the next slide, which includes, of course, the hepatitis B birth dose as well. So next slide. So here you can see just a summary of indicators by country related to the program indicators needed for elimination of mother-to-child transmission of HIV, Hep B, and syphilis. This is a busy slide. I won't go through the details, but if you focus on the last 2 columns, you will see that the 10 out of 23 countries in this assessment, there was an additional country, Algeria, that was part of this assessment. So 10 countries in total have achieved more than 90% hepatitis B birth dose coverage, and 12 countries more than 90% 3-dose coverage. So there is progress, but it is worth noting that many of these countries are high-income countries with relatively smaller epidemics. So some of the bigger countries with greater burden and greater gaps have yet to either scale up hepatitis B birth dose or introduce hepatitis B birth dose. So I think with this, this concludes my presentation with some additional context for the Eastern Mediterranean region. So I will hand over to the next speaker or the moderator. Thank you.
Thank you so much. Thank you again to all of our speakers so far. And again, please do feel free to use the chat box if you have any questions, either in the chat or in the Q&A box in the meantime. For the previous presentations, giving a bit of a background and context to the scope of the problem that we're dealing with and the public health concern. I realize I actually didn't introduce myself at the top of the webinar, but for those who have joined late, I guess it's better that that I wait and introduce myself now before my section. My name is Stephanie Schendale. I'm a technical officer in the WHO headquarters Department of Immunization, Vaccines, and Biologicals. I focus on immunization delivery platforms on the life course and integration team. I'm just going to spend a few minutes today just taking you through the WHO recommendations for Hep B birth dose and some of the challenges, the programmatic challenges with reaching the coverage levels, as CD already alluded to, with the birth dose vaccine. So just to say that all of our WHO vaccine recommendations are rooted in what we call the vaccine position papers. All of these for every antigen are available on the WHO website. And our position paper for hepatitis B was last updated in 2017, but all the recommendations in there are still current and valid. It is still the authority for these recommendations. And the WHO position paper states that at least 3 doses of the hepatitis B vaccination are recommended for all children. This includes starting with a universal birth dose, ideally within 24 hours of birth, and then followed by at least 2 subsequent doses of hepatitis B vaccine for full protection. Most programs, as CD also mentioned, give this hepatitis B subsequent childhood vaccines as part of a combination vaccine in pentavalent or hexavalent, and so therefore it ends up being a full 4-dose program. But actually, when you're just looking at the hepatitis component in it itself, once you have 3 doses, adequate protection is achieved. We've already mentioned this a little bit, but it will continue to come up throughout the rest of the presentations, which is the need to work very closely with the maternal and child health programs in delivering hepatitis B birth dose because of the critical timing of reaching these babies within 24 hours of delivery, ideally. After 24 hours, effectiveness does decline progressively with respect to preventing the maternal, the perinatal transmission, which is what we're really focusing on with Hep B birth dose. There is still some value in giving the birth dose after 24 hours, but when we're really zooming in on eliminating mother-to-child transmission, this 24-hour window is really critical to prevent that transmission. The hepatitis B vaccine is 98 to 100% effective. As I said, once you get the 3 doses, it's safe and it appears to provide lifelong protection. That is, studies to date have not shown that there's a need for any booster doses. Once you have at least 3 doses, you should be good to go. It's most effective as the post-exposure prophylactic, that is prevention of perinatal transmission, when administered as soon as possible after birth. And for this birth dose, it's critical and it's imperative to use a monovalent. So even though countries do have Hep B in their combination vaccines, pentavalent or hexavalent, you cannot use that for the birth dose. The birth dose has to be a monovalent presentation of just hepatitis. This comes in several presentations through UNICEF. You can procure it in 1 or 10 dose vials, and currently Gavi support includes the 10 dose vial presentation. Hepatitis B vaccine is subject to the multi-dose open vial policy, meaning that open vials can be stored in the fridge and reused for up to 28 days if the VBM has not reached its discard point. So the 10-dose vials can be used if kept in proper conditions for the whole month. But hepatitis B vaccine is very, very freeze sensitive, and it's very heat stable. So oftentimes when we're talking about optimal vaccine storage, we're concerned about going above the recommended 2 to 8 degrees and worrying about heat instability. With hepatitis vaccine, we actually have to be more concerned in the other direction. It's very, very subject to damage by freezing. And so back to this point about the critical timing of 24 hours, ideally after delivery. Usually, if there's going to be perinatal transmission, giving the vaccine within 24 hours is going to do the most effective, is going to have the most effective benefits in preventing that transmission. Many programs will like to provide some sort of wiggle room in case, for example, with home deliveries, who maybe the health worker isn't able to reach the baby within that 24 hours. And this doesn't mean that there is no benefit in giving that birth dose late. It's just that it becomes less effective after that 24-hour window. Within 3 days, you still have some pretty decent protection. Up to 7 days, you're already really at the point where the perinatal transmission benefit is no longer really going to be happening. However, there still remains some benefit against horizontal transmission because, as Funmi mentioned in her presentation, a lot of the time hepatitis is transmitted by household contacts or amongst any sort of transmission that can happen even beyond the perinatal period. So it's still valuable to give the vaccine after the 24 hours, but really the effectiveness declines considerably. And the reason that we are so concerned about preventing this early transmission and this early infection is because there's an inverse relationship between the time at which you get infected and the likelihood of hepatitis progressing to a chronic condition. And the chronic condition is what then leads to liver cirrhosis and cancer, as Funmi and our other presenters spoke about already in their presentation. You can see that the the likelihood of progressing to a chronic condition really, really decreases with age. And so preventing it in that early period is the most important thing to focus on. I wanted to show this slide on contraindications because this question does come up a lot, particularly around any time we're talking about vaccinations of newborns. There's obviously high consideration because of the delicate period and the fragility of newborns in those early days of life. But there are actually no specific contraindications to the Hep B birth dose, and it should be given even for premature babies, even for low birth weight, even babies that are small for their gestational age, HIV infected mothers or jaundice. The one concern that is flagged up with giving hepatitis B birth dose to low birth weight babies is that the efficacy of the vaccine is decreased, which just means that it's extra important to ensure that 3 additional doses are given in the childhood period. Given the fact that most vaccine programs do include those 3 extra doses as part of the combination vaccine series, this isn't a problem, and the children are going to be receiving those 3 extra doses. But this is where it becomes really important to ensure that the actual series is completed, not only for hepatitis, but also for the other antigens included in those combination vaccines, particularly around this point of low efficacy in low birth weight babies. Lower efficacy, I should say. So this just shows the coverage globally of hepatitis B birth dose and national immunization programs in 2024. As you can see, the concentration in the African region in particular is where we've been the slowest to increase the introductions. And as CD already mentioned, the introduction of the Gavi funding support is really changing this. We have a lot of interest from countries in the African region to introduce the vaccine, and we hope to see the colors of this map change quickly over the coming years. And this is the same graph that CD showed, but just to show the global picture as well. We're still sitting at 45% globally for timely birth dose coverage. Some regions, such as WIPRO, CRO, are achieving, or sorry, WIPRO and PAHO are achieving much higher coverage, which brings up the global average, but we do still have a long way to go. And part of the challenge of this is that this WUNIC data is really focusing on those countries that are able to report timely coverage, that is delivery under or within the 24-hour window. We have a good question that was raised in the Q&A box, and I'd like to put it in the chat for everyone to see as well. But for those countries or regional colleagues on the call who do have birth dose in your program, who aren't able to disaggregate the coverage data between timely, under 24 hours, and total, we'd like to hear more about how that's being looked at in your data programs, because this is really the way that we can measure if these babies are being reached within that critical timing window. And countries that report data mixed in with over the 24-hour window don't get included in our global coverage or regional coverage for hepatitis B birth dose. Now, I've only got one slide on this because the focus of this webinar is really about promoting the need for and the importance of introducing Hep B birth dose, and not so much focusing on strengthening delivery practices or improving coverage. There's a lot to cover in that topic too, and we should probably schedule a whole other webinar that focuses really on the importance of strengthening delivery practices, linkages with maternal and child health, and other critical NCD programs in the country to increase coverage with birth dose. But we'll schedule that for another time. But just to call out that this is not a regular usual childhood vaccine that can be somewhat easily added into the EPI program. It really requires some very careful and different considerations due to the fact that it has to be delivered in that critical window within 24 hours, and ideally in the maternity ward or in the hospitals directly where the births take place. This is also linked to ensuring and increasing access to skilled delivery so that mothers delivering have not only access to hepatitis B birth dose for their babies, but also all of the other essential newborn care practices and postnatal care that they need in that critical window. So this is an opportunity as well for increasing integration with the maternal child health programs, increasing access to skilled delivery and clean and safe delivery practices, and strengthening the importance of vaccination to babies and mothers even right from birth. So there's a lot more to talk about on the programmatic side, and we hope that you will all come back to a subsequent webinar to discuss that in more detail. I'll close here with just some resources to support introduction that have been developed from WHO. We have guidance documents for introducing birth dose and also for strengthening practices and coverage with the Hep B birth dose, training modules that can be adapted, a readiness assessment to support countries in preparing for introductions, and then also toolkits for decision-making, which CD is going to talk about in more detail in a session coming up. So just a little bit of a teaser for that. And so with that, actually, we're coming to the end of the first half of our webinar, and we're actually a little bit ahead of schedule. So I'm wondering if we want to take a few questions now for any of our first speakers, for Dr. Fumi, CD, and Dr. Jamil, if we have any of those, before we kind of shift gears a little bit more into the decision-making and introduction support. So maybe while I'm looking to see if there's any questions in the chat, specifically, I'll look at the one that I already alluded to. So Dr. Carolina De Navarro, who is one of my colleagues at HQ, has said one of the challenges in monitoring Hep B birth dose coverage is information systems lumping together all monovalent Hep B doses given regardless of age, so whether it's within 24 hours or later. And so this makes it hard for us to actually establish the coverage estimates for timely birth dose. And so our question for the regional colleagues online or any country colleagues who are attending here, if there's any plans to resolve this issue. Sidi, please come in.
No, thanks, Carolina, for the question. I think when the country is intending to introduce a vaccine, the tools need to be revised, especially the data collection tool. For example, for hepatitis B, you need to have these three really indicators. The first one is the number of doses given within 24 hours. The second is the number of doses given after 24 hours. And you have an indicator combining these two. So you need to have at least in your device documents, the data collection tool, the data reporting tool, you need to have these three data sets. So you can really, when you will be reporting, you will have this segmentation of the data. Over.
Thank you, CD. I don't know if actually anybody else is allowed to speak, or if participants have to put their comments in the chat directly. But if anybody else from a country level has anything to add to this particular point, please do add it in the chat. We also have a question, what is the schedule for Hep B vaccination in pregnant and breastfeeding women? So we're talking now about Hep B birth dose for the baby. So it's not to be given to the mother, it's to be given to the baby. And the baby, we're saying that we recommend giving it as soon as possible after birth, ideally within 24 hours. Do we have any other questions for our other speakers?
Stephanie, if I can quickly come in, it's Jamil here. I just noted that the comment in the chat box related to integrating service delivery, prevention and treatment for hepatitis within HIV programs, and also I think there is another comments supporting STI integration as well, and I think that's a really important and critical aspect to highlight. So I just wanted to pick on that. I think our strategies fully support integrated service delivery, and there are sort of clear overlaps and areas where we can harmonize and bring more efficiencies with the integration, and with the declining financial resources available. I think we need to be thinking more sort of more into these integrated service delivery models, and also for EMTCT and immunization and birth dose, I think more programmatic coordination and collaboration between HIV programs, hepatitis programs, maternal and child health and immunization programs is going to be really critical at the country level. So I think that just wanted to pick on that comment, that it really strikes a major area of need at the countries. Thank you.
Thank you so much. It's hard for me to see them since I'm sharing my screen. I can't see everything in the chat as well. So thank you. If any of our other speakers see anything buried in there as well, please do come in. I see a question around WHO recommendations on the use of immunoglobulin. Fumi, do you want to take that question?
Yes, thank you very much. And before I take the question, I wanted to say something to what Jamil had replied to, and I guess I presented it, but that was early in the session, and it's about triple elimination. And triple elimination is one of the protocols for implementing integration. And just to add that there are new tools and new test kits, integrated test kits that will support that integration and triple elimination. And the WHO guidelines on treatment or prophylaxis of pregnant women support that approach of triple elimination. And just to say that this is a prototype for integration, and it has been quite successful so far with the need to scale up. And it is captured within the HIV PMTCT. That's first. Thank you for asking about the immunoglobulin. There's actually no WHO recommendation for providing immunoglobulins for exposed infants, but it is very common practice, especially in high-income countries where it is being used, especially in places like China, where it is given to women who have a very high sufficient viral load and who are hepatitis B antigen positive. I think I also want to highlight that there are multiple interventions for hepatitis prevention, and WHO has flagged the most high impact interventions. And vaccination of mothers, which is very good practice, really is not one of the high impact interventions. Also, immunoglobulin, which is very important practice in some parts of the world, is typically not available in many low middle income countries because of the cold chain requirements and the cost. Now, some studies are ongoing as to use of hepatitis B prophylaxis, and if that will bridge the gap and obviate the need for hepatitis B immunoglobulin. But that research is ongoing, but early results suggest that in the presence of maternal prophylaxis and birth dose, there might not actually be need for immunoglobulin, but there's more to be seen in that. Thank you. Over.
Thank you so much. So in order to keep to time for our subsequent speakers, we'll move on for now, but please keep your questions because we have a longer time frame for questions and answers at the end. Just glad that we could fit a few of them in now. So with that, I'll turn it back to Simba to revisit the poll and see if any of our answers have changed now with these earlier presentations.
Great. Thanks, Steph, and hello everyone once again. So we are going to repeat the poll. It's exactly the same questions. So we try to see if there's been any change in your convictions between when we started the meeting and now. So the questions again are pasted in the chat in French, and I'm going to read them here for the translation. So the first one is, why is the hepatitis B birth dose an important public health intervention? Here we have one correct answer. Is it first, is it that it significantly reduces the risk of chronic hepatitis infection in newborns? It eliminates the need for subsequent Hep B vaccinations. It is only effective in preventing hepatitis B in adults. So one question there, one answer from there, that's correct. Then the second question is, what is the ideal timing for giving the hepatitis B birth dose vaccine? So this is after delivery. What is the ideal time for giving the birth dose vaccine? Is it within 4 weeks? Is it within 24 hours? Is it within 1 week? Is it within 14 days? So one correct answer there. And third question, which 3 diseases are targeted by the triple elimination framework? Is it hepatitis B, HIV, and syphilis? Is it hepatitis B, tuberculosis, and malaria? Is it HIV, syphilis, and tuberculosis? So one correct answer from those 3. Then fourth question, there's no one correct answer here, so it's just to check. Have you used the NITAG recommendation process toolkit in your work? So you say that you've used it, you have not, or you are planning to use it. Yes, no, or planning to use it. Then last question, again, there's no one correct answer, but you can just choose based on your thinking. What do you consider is the biggest challenge in implementing hepatitis B prevention strategies? 5 options. Is it funding? Is it training and education? Is it access to vaccines? Is it access to skilled birth attendants? Or is it public awareness? Thanks, everyone. So, Steph, we show the results now. All right, great. So the first question, why is the hepatitis B birth dose important as a public health intervention? Yes, so almost everyone got it right. It significantly reduces the risk of chronic hepatitis B. This is from the so can we see the results of the first survey, or we cannot? Because what I'm seeing is the results from survey 2.
Yeah, we can't show them both together. I can tell you that it's definitely an increase since the first one. Now we have nearly 100% accuracy.
All right, great. So there's still some 1% who thinks that it is because it's effective in preventing hepatitis B in adults. So I think this has been clarified by all presenters that this is really for preventing mother-to-child transmission, perinatal transmission. So please take note. Then second question, what is the ideal time for giving the hepatitis B birth dose? What was the results on the first poster?
So the result in the first poll was a little bit more mixed than this. Here we have definitely a higher number of accurate results, although I was expecting 100% correct on this one.
Yes. So the correct answer here is within 24 hours. We still have maybe a few 4 people who gave different answers: 4 weeks, 1 week, and 14 days. So I think just to reiterate what has been said already by the presenters, that indeed for us to get the maximum benefit out of this vaccine, we need to give it within 24 hours of delivery. Then the third question, which are the three diseases in the triple elimination framework. Here we see 96% saying HIV, hepatitis B, and syphilis, which is the correct answer. There's someone who still have TB and malaria there in place of HIV and syphilis. Has there been a change from the first poll, Steph?
Yeah, there is a change from the first poll. The first poll we had a few answers on the third choice, so definitely more are getting it correct this time.
All right, great. So some learning has happened there. Then on the fourth question, there's really no correct answer, one correct answer here. So if you use the NITAG recommendation process toolkit in your work, so it looks like most people actually have not used it. The poll is always back. It looks like most people have not used it. Just 8 out of 28 people who participated have used it, 16 haven't, and 4 are planning to. So I think probably we need to do a bit more work to disseminate this process toolkit so that everyone is aware of it and can use it in the decision-making process for their NITAGs. Then the last question, what do you consider the biggest challenge in implementing the hepatitis B prevention strategies? So here it looks like most people say it's the funding, 37%. That's the challenge. We also have a good number which says access to vaccines. That's the second highest, which kind of also is linked to access to funding, really. And fourth, training and education, then access to skilled birth attendants, and public awareness coming on fourth and fifth. So I think it seems like the consensus here is that funding has been a challenge, which has been partly addressed by the Gavi funding, which we are going to talk about in a few moments. But also, I think there's still something that needs to be done in terms of training and education, as people still feel that this is a gap, not a real big difference between that and access to skilled birth attendants and public awareness. So thanks everyone for participating in this poll, and back to you, Steph.
Thanks, Simba. Okay, so luckily we are on time. We can take a 2-minute break in case anyone needs to stand up, stretch, go get a coffee, and we'll be back in 2 minutes with Dr. Sidi again for a discussion on the NITAG toolkit. So 2-minute break, and we'll be back in a few minutes. Perfect. Okay, over to you, please.
Thank you, Steph. So we'll just give an overview of the NITAG toolkit for hepatitis B birth dose decision making. Slides. So this toolkit has been developed by the Task Force for Global Health in collaboration with CDC, WHO headquarters, and regional office for Africa. So myself and my colleague Kabore was working with the task force for this toolkit. So the purpose of this toolkit is to support the African countries in decision making. So it's used by the NITAG and the technical working group to see a synthesis of scientific background on hepatitis B, but also on the birth dose. and also the best practice for hepatitis B birth dose implementation in some of the African countries. So primarily this toolkit is intended to be used in the African region, but can be extended to the other region also, as some of this information are global, and the methodology also used by the NITAC are really standard. Slide. So the structure of the toolkit, you have 5 sections. The first section is about the disease overview. The second is the global and regional hepatitis B virus burden. The third section is related to the vaccine safety, vaccine effectiveness and efficacy. And the fourth section is about the vaccination guidelines and elimination goals, focusing on the triple elimination goals, but also the regional goals in the African region. And you have the last section about the implementation consideration. So there is a long list of implementation consideration that has been developed in this guideline. Slide. So as you know, the NITAC follows 4-step process to guide decision, to inform their decision, and they use this 4-step to fill a tool they called the evidence to recommendation framework. So the 4 steps are the first step is to formulate the policy question into PICO question that can be used to identify which evidence you will be need to make your evidence research. And after you have the step 3, where you will gather the evidence, analyze and synthesize the evidence, and prepare also your technical document. And you have the last step, where the NITAC will discuss the draft recommendation and vote or have consensus on the recommendation. Slide. So slide, please. So this is the first step, defining the population intervention, comparison, outcome, and question. So this is an example of broad policy question, like should a birth dose of hepatitis B vaccine be introduced in Zambia? I've seen Constant online, or in Uganda, and you will define the population, the intervention. Here, the intervention is the first dose of hepatitis B vaccine given immediately after birth, preferably within 24 hours. And you have the comparison is the other doses, subsequent doses given at 6, 10, and 14 weeks. And you have the outcome that are the seroconversion to protective antibody level and prevention of maternal to child transmission. But you can also define another the PICO depending on the consensus you will have within your NITAC. Slide. The second step is the NITAC to define the specific evidence criteria for its PICO and prioritize. So this is a snapshot of the domain 1, the public health program, where you have in the first column the element, so the burden of disease, clinical characteristic of disease, and so on. The second, you have the category of evidence that are needed, so to respond to your element. And what the NITAC will really work on is in the third column, where you will define the specific evidence that you will be collecting to respond to your PICO question. And for each of these evidence, you will prioritize, is it critical for our NITAC to have this evidence to be able to make recommendation, or this evidence is important but not critical for decision making. But you can also, if the evidence is not important for decision making, is just to stroke out this category of evidence you will not be looking for. Slide. So the step 3, really the toolkit is addressing the step 3, the gathering the evidence, analyzing, appraising, and synthesizing the evidence. So here you have the set, the 7 domain. The first domain is the public health problem. So in the toolkit, you will find the Global Hepatitis Report 2017. So I've put on red, so that is will be needed to be updated by the NITAC when you will do this exercise. It's just you will have the indicators in the toolkit, and you can go and find especially the 2024 report, so presented by Fumi. You can find the most recent evidence on that. You have also the global progress report 2021, but 2024 is now available, and the status of hepatitis B control in the African region with the scorecard that can be used. So when you look at in the toolkit, you will have this in section 1 and section 2. So the pages are here, but also in section 4, page 31. You have the second domain of your ETR, that are the benefit and harm of the intervention. Here we are talking about the hepatitis B birth dose. So you have the hepatitis B vaccine WHO position paper, synthesized here in the toolkit. So we will you have also the section 3 and section 4 where you can find this information. For variant preference, especially the implementation of birth dose of hepatitis B in the African region, and the analysis has been done in assessing the implementation in 5 countries: Ethiopia, Senegal, and other countries that you can find so this information. So at section 5, page 46, you will find this information there. So for research use, really that is the strength of this toolkit. Really in the toolkit, you have the cost effectiveness analysis of additional birth dose of hepatitis B. And that is really an argument for the program in these resource constraints, where the Minister of Health will ask you why we are introducing this vaccine, not the other vaccine. So you have all this relevant information on the cost effectiveness at page 40 to 45. And you have the domain on acceptability. So here you have only data on in one country, Nigeria, and the NITAC really, when you will do this exercise, it is important that you generate or you find out the evidence in the country. So on the vaccine acceptability. If not available, you can also see at the country level if this information can be generated. And you have the information in the toolkit as also evidence on the feasibility. Especially the information has been drawn from the guide for introducing and strengthening hepatitis B birth dose vaccine that has been developed by WHO. And the last domain, domain 7, about equity. Also, you have this information extracted from the hepatitis B birth dose introduction guide. So I've put a link on the Global Hepatitis Report 2024 that can be used to update the domain 1. But it is important, in addition to the guideline, that the NITAC find out if there is any information in the country that can be used in every of these domains. Slide. Okay, so the toolkit is in French and English, and it's likely 60 page, but the evidence are in 48 page. So you are very friendly, useful. So just for a reminder, this is a toolkit. So the NITAC need to follow the ETR process to make recommendation and strong recommendation, and especially the implementation aspect. It is important in your recommendation to highlight that how the program need to really design the implementation of this vaccine within the immunization services, but also the maternity wards and in the community. Thank you, Steph.
Thanks, CD. And now we're going to hand it over to Louise. We'll just keep this fast because I know she has to drop off. Thank you, Louise, for being here. Over to you.
Thanks, Stephanie. So I'm going to briefly present on vaccine prioritization and optimization, which was presented at SAGE in March 2025. And when we presented it to SAGE, their recommendations was really that this was a critical piece of work, and they encouraged countries to consider prioritization of future new vaccine introduction, considering the resource constraint environment we live in, and that will get tougher. And also encourage them to look at optimization of their schedules and portfolio. But to do so, this has to be done in a systematic and country-owned process based on existing local infrastructure and ecosystem. And so these recommendations on prioritization and optimization need to be aligned and integrated with the priorities reflected in the NIS or in the health sector strategy, and regularly updated. Next. Next slide. Yes, so how would it look like to make recommendations on prioritization and optimization? So on one side, you have the NITAGs who make antigen-specific recommendation, and then you have the NIS, which is the overall strategy that looks at the next 5 years. Now, what SAGE is encouraging is that the NITAGs, before making a single antigen-specific recommendation, would look at the new vaccines that are yet to be introduced and prioritize them based on the resources and based on a different set of criteria. And they would also do so for optimization, and that would be used to update or to develop the NIS. And to do that prioritization and optimization exercise, they would use an MCDA approach, which is the multi-criteria decision analysis. So it's a bit different to the evidence to recommendation process that the NITAGs are used to. But what is critical here is that the NITAG work feeds the NIS, and that we respect processes and their timeline. Next. So just briefly on prioritization and optimization definitions. When we're talking about prioritization, we're looking at the future. So what are the vaccines that are yet to be introduced? When should they be introduced and in what order? On the contrary, optimization is really looking at the present. So in the current portfolio of vaccines that you have in place in the country, what are the products that could be changed, the presentation that could be more efficient programmatically, and the schedule that could potentially be revised. And so here is the difference, but what we're saying is, and strongly encouraging countries, is to do both prioritization and optimization. Next. So to do this exercise, as I have, as SAGE has recommended, and as I have insisted on the first slide, you really need to have a formalized process that is aligned with the country priorities, and it will serve to anticipate the future of the program and its sustainability. So for prioritization, you're looking at medium to long term, whereas for optimization, you're looking at the short to medium term. Flagging that when there is an optimization decision, it doesn't mean that the switch or the change is implemented straight away. It still requires some time, but it gives a signal both to partners and to manufacturers. Next slide. So for prioritization, we have developed a tool called the New Vaccine Introduction and Prioritization and Sequencing Tool, NVIPST. To do that, we started from the need of countries and of NITAGs that are facing pressure to introduce new vaccines, but these pressure are often siloed. They are driven by political agenda, by the donors' agenda, sometimes by the recommendations from experts, including SAGE. It can also be driven by public and media pressure or by regional and neighboring countries' expectations. And so often this pressure from different parties would result in adoption of very ambitious plans that are not necessarily doable to implement. So if you look at the screenshot in the middle, which is coming from a country that had planned introduction of 1, 2, 3, 4, 5, 6, 7, 8 vaccines in 4 years' time, with 4 vaccines in the same year, you can see that it is almost impossible to do. And this prioritization or this plan would have some financial risks, also instability for the program, and competition of resources between the different health programs, not only immunization, and a lower acceptability of your strategy. Next slide. So with the NVIPST, we try to develop a formalized process that would accompany the NITAGs to make these recommendations around prioritization. And it's a 3 phases process. The first one, you would need to adapt the framework, meaning you would need to look at the vaccines that are yet to be introduced and the criteria that you would want to use to look at these vaccines. During phase 2, you would collect the evidence and for each vaccines according to the selected criteria. And that's when you would you would weigh in and do different scenarios that would lead to the prioritization and the sequencing of these introductions. And then phase 3 is the final phase. Once you have done your scenarios, then you would draft the recommendations and present them to the EPI and to the Ministry of Health. This process is led by the NITAG, but it's in very close collaboration with the program. Next slide. For optimization, we are also developing or adding to the NVI-PST an optimization component. The rationale for doing optimization is not only cost saving, it could be also to improve the coverage, to reduce the waste, or also to respond to market availability and to address disease control. So again, with the optimization process, you would have a similar three-phased approach, and you would also select the different criteria for the different vaccines that you would look at. Next slide. So all of this work around prioritization and optimization is coordinated by a working group that is called VPOP, including WHO, UNICEF, Gavi, GSI, Development Catalyst, with the financial support of the Gates Foundation. And through this working group, we are developing a set of tools and guidance, and we're engaging with technical partners. And so we are also interested in piloting the optimization module that will be made available quite soon and presented at the Global NITAG Network meeting in November. Next slide. So flagging the resources that are available for now and ready for use. So the evidence to recommendation framework remains the main resource and process for NITAG recommendation when they're just looking at one antigen. The NVI-PST is also made available, and you have the link on the slide. It is on the NITAG Resource Center. And what we have developed more recently to speed up the evidence collection process is what we call the Vaccine Evidence Compendium, or Compendium. It is available on the NITAG Resource Center for 4 vaccines: EXA, RSV, PCV, and HPV. So for these 4 vaccines, we have compiled global evidence, so not regional and local, only global evidence. But we've used the same indicators that you have in the ETR and on the NVI-PST. So what you would need to add to that evidence compilation is local, and when it is missing, you would need to add regional evidence. So that is really a useful resources to ensure that your evidence compilation, which is very time consuming, can be facilitated. And I think that's it. Yeah, so as I will be leaving, if there are any questions in the chat regarding prioritization and optimization, I will defer that to CD, but thank you for having me.
Thank you so much, Louise, and sorry for crunching you into this last little window of time. We appreciate you joining. Okay, over to Simba for the Gavi presentation.
Great, thanks, Steph. So once again, everyone, my name is Simba Mabaya, and I'm going to take you in the next few minutes through what Gavi requires for countries to access their support for vaccines. Next slide. So I think for some of you who have been around these discussions for long, you've seen this slide before. It gives kind of a timeline of the support that Gavi has been providing towards the vaccination against hepatitis B. Starting in 2000, where Gavi has been supporting through this multivalent vaccines which included hepatitis B, tetravalent, pentavalent, and now hexavalent. And in 2018, the Gavi board approved support for a monovalent hepatitis B birth dose vaccine, which was supposed to start in 2021, but due to the COVID-19 pandemic, this was delayed and the program was only launched in June 2023. And in June 2023, that's when the board gave approval to proceed, and the program was only launched in July 2024, with the first countries applying then. So just to allay people's anxiety, in July 2025, then the Gavi board again reaffirmed its commitment to maintain support for the Hepatitis B Birth Dose program despite ongoing challenges with global health funding, which everyone is aware of. Next slide. So Gavi supports countries to vaccinate their children with these hepatitis B birth dose vaccines aligned with what WHO recommends. So preferably within 24 hours, as we have said before. And the support that is available currently is through the vaccine doses. And someone has asked about introduction support, which Gavi has been providing as vaccine introduction grants as well as technical assistance. So some of you might know already that starting from 2026 to 2030, Gavi is going to be implementing a new strategy, which we are calling Gavi 6.0. And with these challenges, there's going to be some changes in terms of the architecture of the support that we provide for countries. But in general, there will be support for the procurement of vaccines that's going to continue. But there's also going to be some support, something that is kind of similar to the vaccine introduction grants, but they're not going to be vaccine introduction grants. There's going to be kind of a consolidated envelope that will include support for those kind of activities to facilitate introductions. So all countries that have not introduced the hepatitis B birth dose vaccine that are Gavi eligible can request this support. We had an exception for Ethiopia, Rwanda, and Uganda, and the three of them have already applied. These are countries which had introduced the vaccine before the launch of the Gavi program, but they did this after the 2018 board decision, and because of that, they were considered as not having introduced so that they could access the full range of Gavi support. So there are some key considerations that are needed to be put in the applications. I'm going to talk about this in greater detail in a slide just shortly. Next slide. So there are 54 Gavi eligible countries at the moment, and of those 54, 34 are yet to apply, are yet to introduce the birth dose in their national schedules. And of these 34, as you can see from the list on the left-hand side of the slide, the left-hand side, that 30 of these countries are actually within the African region. So there's still a lot that needs to be done, as CD has already said when he spoke about the status in the African region. But we are happy to announce that we have 12 countries so far that have applied and they've been approved to access Gavi support. We had our first introduction in Eritrea in August of 2025, and we have other 2 introductions that are lined up, 3 introductions that are lined up before the end of the year in Ethiopia, Sudan, and Uganda, and also 2 more that are lined up in the first quarter of next year, Congo Republic and Rwanda. And there are other also 6 that are going to be coming up in the next year. Their applications have already been approved. So there's quite some movement, good demand since July 2024 when the program was launched. We've seen all these applications coming from AFRO region, I think except Sudan, that is not in the AFRO region. Next slide. So Louisa has already spoken in more detail about vaccine prioritization and optimization, but I just want to make the point here that, as I said, that beginning next year, Gavi is going to change the way that countries have been will be accessing support. So previously, countries could come to Gavi with a standalone application for hepatitis B, or they could come as part of what we call the full portfolio planning with request for other vaccines and health system strengthening support. But going forward, starting in 2026, countries will not be able to come with standalone applications. So will not be able to accept, say, a standalone application for hepatitis B birth dose vaccine. Instead, based on the rationale of vaccine prioritization that Louis spoke about, we are going to ask countries to come with a holistic application for the 5-year period. So from 2026 to 2030, countries will be required to provide a holistic application for all the support that they need from Gavi. So that would include all the new vaccines that they want to introduce and what support they need to sustain the vaccines that they've already introduced. So the final details of how this is going to be implemented are still being developed, and they're going to be published sometime at the beginning of next year. But this approach, we hope that it's going to foster kind of a more integrated, sustainable immunization programs. Is going to facilitate us to have kind of a holistic thinking of what we need as immunization programs and what we need based on the complexities of the different countries that we are working in, and can have a kind of a 5-year plan instead of just an ad hoc standalone applications. So this is something that's very important, because what is going to happen is that very soon countries are going to start these discussions for prioritizing the different vaccines, and it will be important for us as people from the hepatitis B community to be able to speak to these issues of vaccine prioritization, be able to speak together, gather the evidence that is needed, using, for example, the tool that CD has spoken about, so that we can be able to engage in these discussions to ensure that based on all the other priorities and needs for the countries, the hepatitis B birth dose can be prioritized. So this is something that's really important, and that we need to think about already before the final details of the support are published from Gavi. Next slide. So there are some things that we've been asking countries to include in the applications, and we're likely going to continue to ask these things when the new guidance is published. So we'll need countries to be able to think about how they are going to introduce their hepatitis B birth dose vaccine programs. What we've seen, I think there's an application that we were talking about earlier today, is that the people who develop the application just assume that the birth dose is one of those childhood vaccines, and then they put all the strategies that they would put, maybe, for example, for introduction of Penta or for another vaccine. So we want countries to think about what they're going to do to improve coordination with maternal and child health services. Because as we've said that this vaccine is given within the first 24 hours of birth, so it is likely that this is a vaccine that's going to be given within the maternity wards, maybe within the labor wards or within the postnatal wards. And as a result of that, this is a vaccine that's going to be given by midwives, not by the usual EPI nurses who give out the other childhood vaccines. So we need to think about what we need to do to capacitate the midwives, to what I need to do about the cold chain, so that this vaccine can be available in labor wards or in postnatal wards. We need to think about what we are going to do to integrate with other birth dose vaccines, BCG, OPV0, and also to think about integration with other programs that are relevant, for example, the control of viral hepatitis, and also all those interventions around the triple elimination that includes for HIV prophylaxis as well as for syphilis. We need to think about, so somebody asked in the chat earlier about the multi-dose vial presentation. So yes, currently the Gavi menu, we only have the 10 dose per vial presentation. And we've heard, I think, from the applications that we have received, that there's been a clear ask from countries, especially in terms of reaching children who are born in outside health facilities. Countries have been asking for this single dose presentation, I think, which is easier to handle when someone's going to go into vaccinating in the community. So at the moment, this is not included in the on the Gavi menu, but there's some discussions that are going on through the market shaping roadmap for these vaccines, and this is something that's being considered, and it might come, but probably not as soon as possible. So not very soon. So I think for us then to start thinking on our applications, we need to think about what we're going to do in terms of the multi-dose open vial policy, so that these vaccines are not wasted. They can be used as much as possible. We just heard that the vaccine can be used for up to 28 days after being opened. So there's really a good opportunity to use most of these vaccines and reduce wastage. So community systems are going to play an important role, particularly for those children who are born outside facilities, but also in terms of creating demand among pregnant women. So we need countries to think about what they're going to do about that. Somebody spoke again earlier about the data systems, which are kind of lumping all the children born within 24 hours and out of 24 hours. So we need to update our data system so that we can be able to capture when the vaccines that is given, because we know that for maximum effectiveness, we want this vaccine to be given within 24 hours. We know that there's still some effectiveness for vertical transmission, maybe up to 7 days, but we need just to be able for us to see the impact of what we are doing. We need to have this captured accurately. And we also have to think about equity, about other challenging geographies. We need to think about what we need to do to empower women to be able to make decisions. We need to think about all the other economically disadvantaged groups in our countries. Countries also need to think about.
Sorry, Alex here. Apologize for interrupting you. Can you please slow down a little bit for the interpretation? That would be. Thank you so
Sorry
much.
yes, sorry
Thank
about
you.
that. Yes, but I'm really almost at the end of my presentation. So countries will need to describe in their applications what they need in terms of TA. Here we're asking countries to indicate how they are going to use all the Gavi support that's available to them through these different grants. But just to mention again that these standalone grants are not going to be there from 2026 going on forward. So there's going to be a different architecture with likely with all these grants put together in one envelope for countries to access. We also then need also countries to indicate how what they will need to do in terms of post-introduction evaluation for these vaccines. I think as much as possible, as WHO recommends, we will ask countries to see if they can put all these post-introduction evaluations together as much as is feasible. But I think this is something that will be thought through as part of the holistic application. Next slide. So just to highlight lastly that I think there were some questions that were raised in the chat regarding strategies for reaching children that are born out of health facilities. And for us to be able to also answer this question in a more comprehensive manner, we are implementing a learning agenda in some countries in Africa, in Ethiopia, Uganda, the Gambia, and in Nigeria. So to describe, to look at what models have been implemented in these countries or will be implemented in these countries, which are promising in terms of increasing the coverage of the birth dose, particularly for children born out of health facilities. And then we'll also disseminate this evidence so that they can help countries that are going to be to be introducing the vaccines. I think we already have some preliminary findings, I think, from the Gambia, and they'll be shared shortly through different forums. So I think that's all from Gavi. Apologies for that speed, and I'll be happy to take any questions. Thank you.
Thank you so much, Simba, and thank you to Louise and CD as well for the previous presentations. We still do have some time for questions. I know that was a lot of information to digest. I've been trying to follow along in the chat and the Q&A to see what other questions are coming up. Maybe before we move on to a new round of questions, I just want to revisit the timeliness again, because it sounds like there's a lot still of questions around understanding the criticality of this 24-hour window versus a late dose, whether or not it's still worth it and whether or not it can still be effective. We really want to make it clear that when you're talking about the prevention of perinatal transmission, so the mother to child transmission, this is where the 24-hour, ideally 24-hour window is crucial. This is where we know that the birth dose is the most effective at preventing that vertical transmission. It is still effective if you give it after 24 hours. Effectiveness declines progressively with each passing day. So it's really, the recommendation is very clear on it as soon as possible, ideally within 24 hours. And that should be the standard that programs should strive towards. However, we all know that the programmatic reality sometimes just doesn't enable that to happen in all cases, whether it be a home delivery that can't be reached within 24 hours, whether it be the unfortunate reality someone has mentioned in the chat around sometimes vaccination clinics aren't vaccinating every day. There are limitations, and this is where it becomes very important that the country establishes a clear policy on this so that health workers, caregivers, supervisors understand what the policy is in country. We don't want to see a situation where babies are turned away because they can't reach within 24 hours, when we know that within 36 hours, 48 hours, there still is effective value in giving the vaccine. So it should be a policy of striving for 24 hours, but whether that window is permissible to 3 days, 7 days, 14 days, this has to be a country decision that has to be clear in the policy, and so that the health workers and stakeholders are aware of exactly what that policy is. There was also a question in the chat just before I turn it over to my co-presenters for additional comments. There was also a question in the chat about cold chain, and so I did want to mention one thing on that. I spoke earlier about how hepatitis B vaccine is very, very heat stable and very freeze sensitive. Because of the heat stability of hepatitis B vaccine, there's been a lot of implementation research around use of hepatitis B vaccine out of the cold chain or in a controlled temperature chain. And this can be an amazing facilitator at actually reaching areas where cold chain capacity is limited, or reaching home birth, for example. This is still an off-label recommendation because none of the manufacturers have conducted the research to be able to change their label for use. So it is still an off-label recommendation, but it is practiced, and there is implementation research to back this up. WHO SAGE has recommended that countries consider this if they are concerned about being able to reach areas where cold chain capacity is limited. And if countries do pursue this to follow the WHO recommendations for use of vaccines in a controlled temperature chain or an out of cold chain use. It is still off-label though, which does unfortunately prevent it from being widely taken up, but it's an opportunity, and there is still research ongoing around this. There's so many questions around programmatic challenges and increasing access and increasing coverage. And this is really, as I said before, it's a subject for a whole other webinar. There's so much to discuss around this, and unfortunately, it just isn't the topic of this one in particular. We didn't want to do this for more than 2 hours. But as Simba mentioned, there's a learning agenda, particularly looking at this as part of the Gavi work in this area, and we know we have so many country experiences. If anyone on the call has anything to share around this, around working with NGOs or local actors to increase access to skilled delivery, for example, or increasing uptake in hospital settings that you could share, please do share them. Either raise your hand or put it in the chat. But we absolutely want to hold a second webinar that really focuses on the programmatic challenges and solutions to be able to increase the coverage for this vaccine, even if we're focusing on just the introduction of it in this particular webinar today. Do we have any new questions? Do any of my co-presenters want to come in while I'm looking at the question box to see if there's anything new that's been added? CD, please come in. I see your hand up.
Yeah, thanks. I think there is a question on the vaccine prioritization and vaccine optimization. So the vaccine prioritization, the NITAC will do this when the country is planning to revise the national immunization strategies, or to apply to Gavi in a full Gavi full portfolio. The question the NITAC is need to respond is which vaccine we prioritize for the next 5 years in the country. Vaccine A, vaccine B, vaccine 1, 2, 3, 4, or 5. And you will consider also the scenario. The first scenario is that the things will be remaining as they are today for the next 5 years. And the scenario 2 is if, for example, the funding landscape change or there is supply concern, what will be the second scenario? This is vaccine prioritization. The second is optimization. Currently, you are using some vaccine where you have the choice to change schedule, like HPV. The countries who are using 2 doses can optimize the schedule going to 1 dose. Or you are using pentavalent, you want to switch to hexavalent. This is a kind of optimization also. or rotavirus vaccine. You have many vaccines in the market. The NITAG can decide to optimize this product also. So, so the optimization is about the schedule, is about the product you are using, is about the strategies you are using, the age range for this vaccine, etc. So that is the response on vaccine optimization. So there was some question also about the hepatitis B birth dose, the implementation. The one message I want to give really is that if the country is planning to introduce hepatitis B birth dose, you need to link the maternal health program with API. You need to include them in the technical working group. As you know, the API, so you have the technical working group. So at the beginning, you need to include the hepatitis B program and also the maternal health program to the planning. And the second message is the training of the healthcare workers. The midwife, if you don't train them, this vaccination cannot be successful. The third is the vaccine should be available at the maternity wards. If you have that three things, you can expect to have the success in the implementation of hepatitis B birth dose. Over.
Thank you so much, CD. We still have a few more minutes. We have a question to Gavi that I'll hand it over to Simba. Then we have a question for Funmi. And I also want to welcome Nicholas Danielson from UNICEF, who's another critical partner in this initiative, to also come in afterwards. So Simba, please, then Funmi, then Nicholas.
Yes, thanks, Steph. Yeah, so I see there are a few questions from Mary Beth. First, what happens to countries that will be in accelerated transition phase? So if a country is in accelerated transition phase, I think you're asking about Kenya specifically. So if the country has not introduced the vaccine, they're still eligible to apply, even if they're in accelerated phase. I think you need just to check again which phase Kenya is, because I know there's been some changes also in the transition policy. Then what will be the impact in terms of vaccine prioritization? So I think still countries even in accelerated transition phase will be expected to go through this VPOP exercise and to prioritize which introductions they want to do between 2026 and 2030. Then what happens to those countries that have finalized their NISs? So I think the actual final mechanics of how this will work are still to be determined, but in as much as is possible, the holistic application that comes to Gavi is going to try to be aligned with what the country already has planned in their NIS. So the final details are going to be really from country to country to see how off the timing of the Gavi application and the NIS are, but I think there's going to be kind of some process to try and align as much as is possible these two processes. Thanks. I think it's over to Funmi.
Yeah, it's Funmi, if you're still there. We have a question about guidelines on hepatitis B positive mothers and immunoglobulin. I just wanted to let you direct to the latest of the global hep guidance documents. And any other questions or any other comments that you want to make, please feel free.
Thank you. I think this question about immunoglobulin comes up very frequently, and I was just typing a response, and I think I would like to make 3 comments. And the WHO in the vaccine I'm trying to turn on my video. I can't do that. Okay, so in the vaccine policy, it clearly understands that hepatitis B immunoglobulin prophylaxis in conjunction with hepatitis B vaccination may be of additional benefit for newborn infants whose mothers are hepatitis B surface antigen and particularly are also E antigen positive. In full-term neonates born to mothers who are hepatitis B surface antigen positive and E antigen negative, protection against perinatally acquired HBV infection may not be significantly improved by the addition of hepatitis B immunoglobulin to HBV vaccine given within 24 hours. And having said that, in addition, in many high-income countries, HB immunoglobulin is given, but in many low middle-income countries, cold chain storage and costs of the vaccine are prohibitive. With the new WHO guidelines recommending hepatitis B prophylaxis for pregnant women, there is increasing evidence that immunoglobulin may not be required where you have combination prophylaxis for PMTCT. And there are evidence coming from Africa and other countries. So there's a lot of consideration for immunoglobulins, and it's not a specific WHO recommendation, actually. It's common practice in some parts of the world. I think I'll stop at that, and it's something we can discuss further. Thank you, and over.
Thank you so much. I know that we're at time, but I did offer the floor to Nicholas Danielson. So if you're still there and you want to add anything from the UNICEF perspective, just to close us off, because I know that you're very involved in this portfolio overall. Maybe he's not there.
Sorry, one last common practice we see. In some countries, they are vaccinating pregnant women, and that is not a WHO recommendation to vaccinate pregnant women. And the program is going to need to do the cost effectiveness of vaccinating negative women versus using the funding for universal hepatitis B birth dose. So really it's cost effectiveness. There's no specific recommendation for vaccinating pregnant women who are negative. Even though in some countries now, we know that in the US, there is a push towards a once in a lifetime screening and then vaccination of many people. In highly endemic countries, however, one needs to do more than surface antigen. One needs to check for the antibodies because a high proportion of women who may be surface antigen positive or who may be surface antigen negative have antibodies that render them not susceptible to further infection. So there's a lot to discuss in this vaccination for pregnant women. Thank you, Anova.
Stephanie?
Absolutely. And this just goes to show that even a 2-hour webinar is not enough time to cover everything. Hepatitis B birth dose is just one small part of an overall comprehensive strategy for viral hep control and elimination. And we could also talk about other vulnerable groups that should be targeted for vaccination, such as health workers or others at high risk exposure. Ideally, we want everybody in the population to be protected, and so that we don't have to worry so much about things like perinatal transmission. But while we're still, in the situation where we have that case, birth dose remains a tool, a really cost-effective tool, very, very low-cost vaccine that can do so much good and has such high impact to deliver. And so it's just one piece of the puzzle. Nicholas, you're unmuted. Please come in.
Yeah, thank you. And I'll be very, very quick. I just want to reinforce what Sidi said last time. I mean, if and when you introduce a birth dose, you have children who are born in facilities, and on average, that's every second child in sub-Saharan Africa. In many countries, it's 70, 80, 90% of children. And that's a captured audience. But if you want that birth dose to be given within 24 hours, my experience is that you need to find a way of storing the vaccine in the delivery ward, of delegating the administration, the vaccination to the staff in the delivery ward, nurses and midwives, and that the injection, the vaccination with the hepatitis birth dose becomes part of standard newborn care. The thing that you do with the baby, everything you do when the baby is born, you check, you also give the hepatitis B birth dose. The other two birth dose vaccines, OPV0 and BCG, they don't have the same, that's not as critical that those vaccines are given within 24 hours. So there could be a situation where you delegate the vaccination with the hepatitis B birth dose to delivery ward staff, and OPV and BCG is given by immunization staff, which is less critical. And the reason I'm saying this is that it is not unusual for mothers to leave the delivery ward on a weekend or during night, and those babies will miss the birth dose if the administration is organized by immunization staff at certain times on weekdays, for example.
Thank you so much, Nicholas. And clearly, as I've said already, we absolutely need to have a whole second half of this webinar where we really focus on particularly the programmatic issues, challenges, and solutions, success stories that we know countries are doing quite well at achieving high coverage, and others that are struggling. So everybody who's interested in that aspect of this discussion, please stay tuned. We will schedule that in the coming months, and we hope you can come back and join us. I know we've gone over, I think we might have lost our interpreters already. If not yet, thank you to Emily, and thank you to all of the co-presenters and other subject matter experts that have joined today to make this possible, and to Alex and TechNet for facilitating. We will share the slides and the recording, and any questions that were unanswered, please feel free to write in or post them on TechNet, because we always have an ongoing dialogue on the TechNet forum as well, where these questions can be raised and responded to. With that, I think that's all. Alex, anything else, or we close here?
Thank you so much. I think we can close now.
Bye, everyone.
Thank you, everyone. Bye-bye.
Thank you.
Bye.